Hello, folks. My name is James, and today we are discussing hyperprolactinemia, a situation where your pituitary gland overdrives the production of prolactins. But there is always a way to turn down the music. First, let's take a look at the medical mnemonics that describes the causes of hyperprolactinemia. Physiological factors such as pregnancy, breastfeeding, stress, exercise, coitus, and sleep may increase prolactin levels. Renal failure may lead to decreased clearance of prolactins as well as impaired degradation. So it is not uncommon to see patients with chronic kidney diseases show signs and symptoms of libido loss. Now, according to one study, prolactin levels in patients with chronic renal failure normalized after renal transplantation, but interestingly, dialysis did not alter the prolactin levels. Ovarian disorders such as polycystic ovarian syndrome may also lead to an increase in prolactin levels. The hypothesis could be linked to the fact that both disorders share the hypothalamic pituitary axis. Note also that prolactins are under the constant tonic inhibition by dopamines. Studies have shown an increase in prolactin levels after a surge in luteinization hormone, and also estrogens have shown to increase prolactin levels. In summary, whenever you notice menstrual irregularities plus elevated testosterone, you're most likely dealing with a polycystic ovarian syndrome. Macroprolactins, these are very big prolactins, however, they are biologically inactive and they retain the property to interfere with immunological assays for determining the usual monomeric prolactin levels. Macroprolactins have a higher molecular mass and they are bound to immunoglobulin, so they have this prolonged clearance that is similar to immunoglobulins. Usually, you would consider macroprolactins in cases such as absence of symptoms, mildly elevated prolactin levels, a normal pituitary gland, and a normal menstrual cycle. Acromegaly. So growth hormone producing tumors may actually be a macroadenoma. By that we mean an adenoma that is greater than 1 centimeter, or an adenoma that is less than 1 centimeter will be referred to as microadenoma. So these sort of adenomas may also co-secrete prolactin levels. Now, a stalk effect is also an important factor to note because most of acromegaly tumors are macroadenomas and they can actually compress the pituitary stalk and lead to a compression disinhibition that leads to a decrease in dopamine because prolactins are under constant or tonic inhibition by dopamine, and the dopamine fibers run through the pituitary stalk, and so any compression will lead to that compression disinhibition. Cirrhosis. Now, some studies have suggested a significant increase in prolactin levels with severe liver diseases, which presents as hepatic encephalopathy and ascites. However, the mechanism is still not properly understood. Therapeutic factors. Dopamine antagonists may increase prolactin levels. Among such drugs include phenothiazine, metoclopramide, methyl-dopa, among many others. Trauma may also lead to the damage to the stalk or the hypothalamus that will also lead to a reduction in the tonic inhibition of prolactins by dopamine. TSH elevation. In hypothyroidism, TSH is elevated, and that stimulus can overcome dopamine inhibition on prolactin secretion. This in fact can lead to prolactin increase. Infiltrative diseases, such as with granulomas or irradiation, may damage the hypothalamus and lead to a decline in dopamine levels. These granulomas may also compress the pituitary stalk and lead to a compression disinhibition and further increase in prolactin levels. Neoplasia. Prolactin secreting adenoma accounts for 30% of all pituitary tumors. Microadenoma, which is less than 1 centimeter, is responsible for majority of the cases. Macroadenoma, greater than 1 centimeter, may obstruct or compress the stalk and lead to decline in dopamine as well as excessive prolactin release. Craniopharyngioma, meningioma, or dysgerminoma may also enlarge to compress the pituitary stalk and lead to compression disinhibition. Empty cellular syndrome. What I've depicted on the left is a normal pituitary gland. So what I have here is the hypothalamus. Then we can notice the stalk of the pituitary gland. And we can see the dura, as well as the green one is the arachnoid, and the pia mater is also on top. Now in between them, we can see the cerebral spinal fluid. So what I want you to take note of is the diaphragm, which is this part here that sort of prevents the cerebral spinal fluid from entering the anterior lobe. Now in empty cellular syndrome, what you'd notice is that the CSF has gone into the anterior lobe because of the invagination or herniation of the suprasellar diaphragm. And this can often also lead to impingement or compression of the pituitary gland and increase the prolactin levels. Epileptic seizures. Epileptic signals are transmitted from the temporal lobe to the hypothalamic pituitary axis. That stimulus may be high enough to overcome dopamine inhibition of the prolactin secretion, and this can lead to prolactin increase. Stalk effect. Any tumor, such as a craniopharyngioma, meningioma, dysgerminoma, or any tumor that is big enough to compress the pituitary stalk, which we have right here, may lead to a compressive disinhibition and a decline in dopamine. Now, in short, anytime you find hypothyroidism, where you would see an increase in the TSH, an increase in the TSH can in fact also inhibit the dopamine fibers. So anytime you see hypothyroidism with hyperprolactinemia and hypogonadism, you could probably consider a stalk effect. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.